I'll keep admitting people, but we're down to our last presentation of our first day, and yay to everybody who has come and supported all of the students. It's ran, I think, pretty smoothly, considering we've not done this before. So our last presenter of today is Audrey Anderson, and she is going to be presenting her project work that is titled Supported Recommendations for Acetaminophen Use in the Perioperative Center. So I will turn the screen over to you, Audrey. Make sure you have unmuted yourself, and we will.
Okay, thank you. Are you able to hear me okay?
Yes, we can.
Okay, perfect. So as she said, my name is Audrey Anderson, and I'm a registered nurse anesthesia intern, and I will be presenting on supported recommendations for acetaminophen use in the perioperative setting. Acetaminophen is frequently used in the perioperative setting. It is used in the treatment of mild to moderate pain in children and adults. It is available in 3 routes: oral, intravenous, or IV, and rectal. Furthermore, it is a non-opioid analgesic. It has known therapeutic effectiveness in humans, as well as a low number of associated side effects and drug interactions. The IV acetaminophen formulation, otherwise known as Offermev in the United States, is popular in the perioperative setting. This drug is attractive to anesthesia providers due to the rapid time to peak plasma concentration and the rapid analgesic effects. However, a double-blind randomized controlled trial found no correlation between plasma concentrations and efficacy of the drug. The disadvantage of IV acetaminophen or Offermev is the high cost when compared to other formulations, as well as patient inconvenience and the potential for infection, phlebitis, and hypersensitivity reactions. At the target hospital, there is a 200% cost difference between IV and oral acetaminophen. The use of IV acetaminophen has not shown higher efficacy over oral doses in managing pain control in multiple studies. Therefore, without carefully considering the patient factors which warrant the IV administration, the use of IV acetaminophen over the oral formulation can potentially yield unnecessary high costs while failing to significantly change patient outcomes. The problem statement in this project is that the acetaminophen route choice at the target hospital was at the discretion of the anesthesia provider, a poorly defined process. As the outlook on the healthcare system changes in the United States and continues to evolve, cost containment within hospitals will need to be carefully balanced with measures to improve quality of care and patient outcomes, especially when you consider the impact of these indicators on hospital reimbursement. A standardized approach for acetaminophen administration planned to bring the evidence to the clinical arena to support a multimodal analgesic approach and reduce the use of IV acetaminophen without the proper indications. For certified registered nurse anesthetists at a community-based, not-for-profit Midwestern hospital, the current practice was to utilize IV acetaminophen over the oral formulation in the perioperative period. This was a practice which became a financial burden to the organization. The clinical question was, in adult surgical patients, how did the administration of IV acetaminophen compared to the administration of oral acetaminophen affect cost savings in the perioperative period? The purpose of this project was to improve the decision-making process for anesthesia providers in choosing oral versus IV acetaminophen to administer within the perioperative setting based on the current evidence. Based on the aim of this project, the plan was to modify the current policy used at the institution to restrict IV acetaminophen use, and then make practice recommendations for acetaminophen use and formulation choice. Improving provider decision-making was projected to reduce unnecessary administration of the IV formulation. Reducing the use of IV acetaminophen through increased utilization of the oral formulation and other non-opioid analgesics was projected to reduce costs for both the patient and the hospital, while continuing to adequately cover perioperative pain. You can review the search terms utilized in performing this literature review on the slide. The search terms were mostly limited to the years 2012 to 2019. After eliminating unsuitable articles, the literature review yielded a total of 29 articles. The literature involved includes pain management, IV and oral acetaminophen use, multimodal analgesia, and a comparison of outcomes between oral and IV acetaminophen. There were 3 articles which compared IV and oral acetaminophen that were of higher merit, 1 randomized controlled trial, a systematic review, and a systematic review/meta-analysis. The table on the slide displays the time to peak concentration in the cerebrospinal fluid, or CSF, and the plasma. The CSF area under the concentration time curve from 0 to 6 hours, the peak plasma concentration, and the duration of action between 1,000 milligrams of IV acetaminophen and 1,000 milligrams of oral acetaminophen. Note the difference in time to peak concentration between IV and oral acetaminophen is 15 minutes versus 45 minutes. However, it is also important to note that the plasma concentrations are equivalent between oral and IV formulations at 45 minutes due to the steep decline in the plasma concentration after the IV formulation peaks. Also note the significant gap in concentrations within the plasma and the CSF between formulations. Regardless of this gap, the bioavailability of the drug is similar after each formulation has reached peak plasma concentration, and there's no evidence to suggest that a hastened peak plasma concentration correlates to enhanced clinical efficacy or patient outcomes. And then you can finally note that the duration of action is 4 to 6 hours for both formulations. Part of the literature review was to establish the efficacy of the IV versus oral formulations. Brett et al. 2012 compared the pharmacokinetics with clinical outcomes such as pain control and opioid requirements. There was no difference in opioid requirements between the IV and oral groups, nor pain scores between these groups upon drawing venous blood samples to measure plasma concentration. This suggests, again, that plasma concentration and efficacy may not correlate between the formulations. 4 studies discussed the efficacy of oral acetaminophen compared to IV when measuring different clinical outcomes such as pain, opioid consumption, post-anesthesia care unit and hospital length of stay, time until requiring first dose of opioids for breakthrough pain, time until ambulating 10 feet, and postoperative complications. There were no significant differences found in the measured outcomes in 3 studies. Multiple studies found that IV acetaminophen did not prove to be more effective than oral acetaminophen in pain control postoperatively. This finding was also confirmed within guidelines by multiple organizations, including the American Pain Society, the American Society of Regional Anesthesia and Pain Medicine, and the American Society of Anesthesiologists, or ASA. Therefore, in translating the evidence, the clinician could consider utilization of oral acetaminophen over the IV formulation if the contraindications are absent. The theoretical model and framework used in this project was Kurt Lewin's theory of plan change. This was a change approach that involved 3 components: unfreezing, transitioning, and refreezing. The first stage was unfreezing, which actively challenges the current way of doing a task or exposes a problem within a current process. The second stage is transitioning, which moves towards process improvement through evidence and implementation, while having a plan to respond to negative forces, such as change resistance. And finally, the refreezing phase ingrains the process as the new status quo, through periodically reinforcing the concepts of the process and commending the staff for implementation success. This is the original IV acetaminophen restriction and standardization policy. The policy has a dose standardization table to ensure dosing was accurate and consistent across the institution. It restricted anesthesia and surgery usage to intraoperative and postoperative care, with orders limited to a 24-hour period, but failed to indicate when the 24-hour period commenced. Finally, it failed to provide any alternatives to the IV formulation of the drug, the evidence behind the use of the IV formulation, nor evidence for using the oral formulation of the drug. The study design in this project was a retrospective chart review over 4 months to evaluate the use of Offermev at this institution during the perioperative period. The sample size was 100 charts. This was determined by the number of surgical cases within the 4-month retrospective review, as well as inclusion and exclusion criteria set by the principal investigator, or PI. About 600 doses of IV acetaminophen were administered by anesthesia providers between February and May of 2019. The sample size was randomized using Microsoft Excel. After the charts were randomized, 100 charts, which met exclusion and inclusion criteria, were utilized for the retrospective chart review in order to make the chart review more manageable for the PI. This project was approved by the Institutional Review Board at the Target Hospital and Millikan University. It was exempt from review for research involving human participants, since the PI was only collecting existing data and records for review. The subjects were de-identified by one of the key stakeholders who assisted with compiling data from the charts, and the subjects continued to be identified as the data was recorded on the data collection tool, and no identifiable data was stored during this quality improvement project by the PI. These are the methodology steps for change. First step, the PI collected retrospective data via patient charts from February to May of 2019 of all patients who underwent surgical intervention and received Offermev at this institution during the perioperative period. This period was defined as 2 hours prior to the procedure through the intraoperative period and then postoperatively for 24 hours past the start time of the surgical intervention. The second step, the PI compared the administration of Offermev to the current institution protocol. Third, the PI determined outliers of the protocol and the cost of those outliers. Fourth, the PI determined anesthesia impact of institution cost of Offermev. Then 5, based on the use and evidence, the PI assisted the key stakeholders in updating the current Offermev policy at this institution. 6, the PI implemented changes to the institution policy after approval by the Pharmacy and Therapeutics Committee. 7, the plan was to inform providers of the changes to the institution policy and the addition of a decision-making algorithm through an educational PowerPoint. 8, the PI made recommendations for future supported improvements to acetaminophen use in the perioperative setting. And finally, the plan was to collect retrospective data via patient charts after implementation of the QI change for a 1-month period to evaluate the change using the same data collection tool used previously. A current cost analysis was obtained from the institution through the retrospective chart review and a wholesale cost analysis. The chart on the slide displays a comparison of costs between 1,000 milligrams or 1 gram of IV, oral, and rectal acetaminophen for both the organization and the patient. 1 gram of IV acetaminophen costs the organization $27.83, and the patient is charged $100. 1 gram of oral acetaminophen costs the organization 2 cents, and the patient is charged 80 cents. Finally, 1 gram of rectal acetaminophen costs the organization 64 cents, and the patient is charged $1.60. Calculating these cost savings to the institution and comparing the wholesale costs before modifying the policy for acetaminophen administration gave support to this project and influence among the key stakeholders. If the pace of IV acetaminophen administration intraoperatively by anesthesia providers was consistent throughout the year, the hospital was projected to spend about $50,000 on IV acetaminophen during the year of 2019, with a projected 1,800 doses administered. As a potential target, if providers were able to administer 1/3 of the projected doses orally, or 600 doses of oral acetaminophen out of the 1,800 projected IV doses, the target hospital could save over $16,500 in 1 year. However, a post-implementation chart review would be necessary to determine the true cost savings. These are the results from the retrospective chart review pre-implementation. Within the 100 charts chosen by random selection for the pre-implementation chart review, there were 20 instances of original policy outliers. The outliers consisted of any patients who received a dose of IV acetaminophen greater than 24 hours past the surgical start time. The outliers were from 3 surgical types: colorectal or digestive, urology, and orthopedic. Comparing the cost to the institution for the 20 outlier doses of IV acetaminophen versus the cost of 20 doses of oral and rectal acetaminophen showed potential for improvement in cost savings. Costs for 20 IV doses of acetaminophen post-operatively was $556.60. When comparing the cost of IV to rectal acetaminophen, 20 equivalent doses of rectal acetaminophen in lieu of IV would cost the institution $12.80. When comparing the cost of IV to oral acetaminophen, 20 equivalent doses of oral acetaminophen in lieu of IV would cost the institution 40 cents. This chart determined the impact of institution costs for acetaminophen doses administered by anesthesia providers within the 4 months. This compares 600 IV doses that were administered. The institution spent $16,698 on 600 doses of IV acetaminophen administered by anesthesia providers in 4 months. The institution could have spent $12 on 600 doses of oral acetaminophen in lieu of IV, or $384 on 600 doses of rectal acetaminophen in lieu of IV. This chart shows the projected impact for 1 year of IV acetaminophen at the administration pace determined in the 4-month retrospective chart review, which we previously have discussed. But if the pace of IV acetaminophen administration was consistent throughout the year, the hospital was projected to spend about $50,000 on 1,800 doses of acetaminophen IV. When you compare this cost to an oral dose of acetaminophen, the projected cost of 1,800 doses of oral acetaminophen would be $36. 1,800 doses of rectal acetaminophen would cost $1,152. This is the policy for IV acetaminophen at the target hospital after it was modified. The pre-implementation chart review data was discussed with the key stakeholders, and an initial cost savings decision was made. The policy was changed to allow for only a single dose of IV acetaminophen post-operatively, if IV acetaminophen was not used intraoperatively. This followed an initiative that was successfully used at Boston Medical Center, as well as the literature review. After 1 dose of IV acetaminophen in the perioperative period, the provider would be expected to consider transitioning to alternative acetaminophen routes or alternative pain medications. Additional doses of IV acetaminophen, in which surgeons desired to prescribe outside of the policy, were required to be discussed on a case-by-case basis with a pharmacist. This is the decision-making algorithm that was created by the PI for anesthesia providers. It's titled Restriction of Use Form for Intravenous Acetaminophen. This algorithm leads the provider through a series of considerations in order to come to a final decision on acetaminophen administration and whether to consider giving the oral formulation in the preoperative area. The algorithm also guided the provider through recommendations for clinical use of IV acetaminophen. The first component of the algorithm asks whether the patient has an allergy to acetaminophen or severe acute liver disease. If the patient has one or both of those conditions, the provider was made aware that the use of acetaminophen is contraindicated and to consider other opioid-sparing alternatives, such as ketorolac, dexmedetomidine, or ketamine, if not also contraindicated. As the provider continues to follow the algorithm, they are asked about other considerations, such as renal impairment with specific creatinine clearance recommendations, and considerations for patients with chronic liver disease. The provider continues through the algorithm to decide whether the patient has any relative contraindications or considerations that would inhibit them from safely receiving oral acetaminophen preemptively in the preoperative area. These include pregnant women, morbid obesity, hiatal hernia, uncontrolled gastroesophageal reflux disease, or GERD, bowel obstruction, enteral tube feedings, and difficult airway. If no contraindications were noted by the provider, then the provider is asked to order oral acetaminophen in the preoperative area with a small sip of water for the preoperative nurses to administer. There is also a dosing recommendations table within this algorithm, which matches the policy at the institution. For patients who are deemed unable to receive oral acetaminophen due to contraindications, the provider is then asked to consider IV recommendations for pediatrics, general anesthesia, and regional anesthesia. The algorithm asks the providers to consider giving rectal acetaminophen to any pediatric patient under 5 years old. Although the pediatric population was not the focus of this QI project, the pharmacist asked that this consideration be added to the algorithm from the previous policy, since the pediatric patient receives IV acetaminophen frequently at this institution. If the provider is administering a general anesthetic with opioids on induction, they are asked to consider administering 1 dose of IV acetaminophen on emergence from anesthesia or en route to the recovery room, while utilizing other opioid-sparing alternatives during the case. This recommendation relates to the 45-minute peak of IV acetaminophen after administration and the duration of action. If opioids are used on induction and the patient will be maintained under general anesthesia with inhalational agents, the patient would receive the most benefit from IV acetaminophen at the end of a general anesthetic as the patient transitions to the recovery room. The administration timing could give the patient up to 4 to 6 hours of pain control postoperatively. The provider can administer IV acetaminophen intraoperatively if other opioid-sparing alternatives are contraindicated. The last thing the algorithm asks the provider to consider is to avoid the use of IV acetaminophen if the patient has a successful neuraxial block or a peripheral nerve block for cost savings purposes. The PI received approval from the key stakeholders after creation of the decision-making algorithm and modification of the policy. This was presented and received approval at the Pharmacy and Therapeutics meeting at the target hospital, which is made up of several physicians, nurses, and pharmacists. Algorithm and policy modification were approved by all key stakeholders and the P&T committee to go into effect within the policy platform on the institution's intranet system. The PI created an educational presentation, which was planned to be placed on the computer-based learning network through the institution's education department. For sustainability purposes, the PI planned for anesthesia providers to complete the CBL on an annual basis and for it to remain as a resource at any time. The target hospital became affiliated with a large multi-hospital health system in October of 2019. Prior to having the education presentation placed on the CBL network, the PI was contacted on December 9th of 2019 by the director of pharmacy at the institution. The PI was informed of the parent health system's projected plan to remove IV acetaminophen completely from the formulary for cost savings reasons at the target institution. This projected plan by the administrators at the affiliation organization to remove IV acetaminophen from the formulary prevented the PI from moving forward with the IV acetaminophen policy and decision-making algorithm. The PI met with key stakeholders regarding this change, and the decision was made to conclude the project, knowing that the drug would be removed at a point in the future. We felt that continuing to implement this project, knowing the plans for the drug at this institution, and educating anesthesia providers on a process change that would not come into fruition would not be cost-effective or a beneficial use of the anesthesia provider's time at work. The pharmacy began working on their own timeline at that point, and the decision as to when the drug was removed from the formulary was up to the leadership at the parent health system. Prior to the change in course, the PI had planned to implement the algorithm policy for a 1-month period, then complete a post-implementation chart review using the same data collection tool used previously, and compare the findings to the previous chart review. The plan was to evaluate for improvement in anesthesia provider decision-making, a reduction in the use of IV acetaminophen after implementing the new decision-making algorithm and policy, and then finally an overall cost savings for the target institution. The conclusion of the project prior to implementation became a limitation, but also a learning experience for the PI, as it revealed a significant difference between choices made at an administrative level versus the clinical level. Removing IV acetaminophen completely from the formulary at the target hospital limits providers' options in treating their patients for pain, whereas a restriction of use policy recognized the benefit of keeping IV acetaminophen on formulary for special patient cases and conditions. Creasy 2014 found that the priorities of the administrators do not always match the priorities of the project leader in a quality improvement project. The problem was noted with this project when reducing the cost to the institution was made more of a priority to administrators than patient benefit. After the target institution affiliated with the parent health system, the original key stakeholders in this project were no longer in a leadership position to make formulary decisions. The major change in leadership and the decisions that came along with this change were the main reasons this QI project was not achieved. These are the recommendations for the future. I recommend adopting a pain management-focused enhanced recovery after surgery protocol, which may be a benefit to this institution in the future. This is a protocol which includes the use of oral acetaminophen as well as other non-opioid and multimodal analgesics. These medications are given in a bundle to cover a variety of receptors and pain pathways, and these ultimately produce a synergistic effect. ERAS includes a standardized pathway of care for surgical patients from the preoperative through the postoperative phase. It includes pre-admission, counseling, optimization of nutrition, standardized analgesic and anesthetic regimens, and early mobilization, with the aim to preserve organ function and decrease surgical stress response. The purpose of ERAS is to improve patient outcomes within the perioperative period through increasing the rate of recovery, reducing complications, and improving the potential for an earlier discharge. Recently, one orthopedic surgeon at the target institution independently decided to implement the oral medication ERAS pain management bundle for his patients in the preoperative and postoperative phase, which would allow outcomes to be easily measured in his patients. This bundle of medications includes oral dosing of gabapentin, celecoxib, and acetaminophen preoperatively, as well as scheduled dosing of these medications in the postoperative period. Based on the outcomes, this protocol could be utilized by other orthopedic surgeons and additionally for other surgical types. The significance of this QI project was to improve the decision-making process for anesthesia providers in choosing oral versus IV acetaminophen within the perioperative setting based on current evidence. IV acetaminophen did not show superiority over the oral acetaminophen in terms of pain management or patient outcomes. Therefore, it is recommended that oral acetaminophen be the first-line formulation over IV when it is not contraindicated. The affiliation organization's projected plans to remove IV acetaminophen from the formulary at the target hospital for cost savings purposes prevented this project from transitioning through implementation to completion. However, there were still multiple takeaways from this QI project. The first takeaway is that the current outlook on the healthcare system reveals a focus on improving outcomes, but also a focus on concurrently reducing expenses and improving the financial stability of healthcare institutions. The second takeaway is that it is critical that cost alone does not overshadow patient needs and outcomes, as this produces a segmented, narrow thought process on quality improvement. And finally, the third takeaway is that all relative factors should be considered on a comprehensive level in change projects, especially in the healthcare system, where customer service and patient outcomes are key. I would like to acknowledge Dr. Elizabeth Gebhardt, my DMP chair, Dr. Dana Flatley, my CRNA mentor, Dr. Jacoby and Dr. Saros, my anesthesiologist mentors, and Chelsea Fitzgerald, my pharmacist mentor. These are my references.
Questions from the audience for Audrey this afternoon?
Excellent presentation. Wow.
Thanks, Holly.
Very, very, very good, Audrey. I'm really proud of you.
Thanks, Dr. Bentley.
Yeah, I think that, again, it was, Audrey couldn't talk about all the things that she had to go through because of the changes in administration within the health system and merging. And, you know, she worked through them great. She had a great rapport with the pharmacists here at DMH, and she just did a lot of amazing work, and I'm very proud of her. She had to work hard.
Good job, Audrey.
Good job, Audrey.
Congratulations.
Thanks, everybody.
Yay!
Yay.
Because you did. You worked very hard. You dealt with some extremely difficult circumstances, especially with the project coming to a premature end, but you have done a fantastic job in your paper and in your presentation of still presenting everything that you did and tying it together and really doing it very gracefully. So congratulations.
Thank you.
Good job, Audrey.